Coming up today, cowboys don't get prostate cancer. Well, that's what this one thought. How this husband and father overcame his denial and found the right doctor to guide him through treatment. Good morning, I'm Jessica Lovell and welcome to the Morning Medical Update. Prostate cancer is the second most common cancer in men, but for many, it is still really hard to talk about. Today, we are meeting a proud husband and father who ignored his past, a flashing red warning sign. But when denial caught up with him, he sought a second opinion and placed his trust in a doctor who helped change his life.
This farm it was originally an 80-acre. My grandfather bought it. This whole area is where I had all my corrals and where I kept my horses and things. I'd lived a healthy lifestyle my whole life. I was in decent shape. Cowboys don't get prostate cancer.
That's what Doug Babcock had convinced himself of, even with a father and grandfather who both had prostate cancer. But the day his call came was still a shock.
It was so surreal. I can't believe I'm sitting here and a doctor's telling me that I've got prostate cancer and that it's a moderately aggressive type. And he says, we'll go ahead and schedule you for a biopsy. And the little fellow that is doing our hay now just finished baling this, and he'll be hauling it out of here after work today. But I think it was ego, a lot of it. It was just ego. I was embarrassed. Always thought of myself as kind of a tough guy.
He was referred to the University of Kansas Cancer Center and urologic oncologist Dr. William Parker.
I'm at war with prostate cancer, and I'm going to lead you into battle, and I'm going to make sure I do everything I can to help you.
Doug had spent years on this property, raising his family and horses. Retired now from horse roping and training, he took time and weighed his options with his wife, Dana. Doug was certain he wanted his prostate out. Weeks after meeting Dr. Parker, Doug went in for his procedure.
All this denial and all this trying to act tough for my kids, my wife. And he came walking in there, and I got really emotional. He said, "Hey, it's going to be okay." I said, "I know, I feel horrible about what I put my family through and all this." And he said, "You just relax now, let me take care of it." I just remember how good I felt to be in his hands.
Doug now calls Dr. Parker his friend and has joined him in trying to break the tough guy stigma surrounding prostate cancer, starting with his own sons, harping on them to get their screenings.
I've never been this happy in my life, which is a strange thing to say when you just had your prostate removed with cancer.
And we're so glad to have Doug here in the studio with us this morning, along with his friend and Dr. Will Parker, urologic oncologist here at the Cancer Center. And we also have his other friend, Jenny Quinn. She is a nurse practitioner who is kind of an extension of Dr. Parker. She works alongside him. I kind of said we got the band back together this morning. And you are the lead singer, my friend. Right. It's so great to have you guys back together, and you just doing so well.
Thank you.
You said that you were in denial for quite a while, even though this ran in the family. What kept you believing that this couldn't really be prostate cancer?
I guess my ego, when it comes down to it, and I'm embarrassed to say now that at the time I was just embarrassed. I had this idea that there'd be a stigma attached, you know.
Yeah.
Not a tough guy anymore. Not a man anymore. Just things like that. And I did what all reasonable people do. You go to the internet and you say, well, what are the other things that can cause your PSA to be elevated? And you just read through 100 of them or so, and then you finally get to the one that makes that you want to go with.
Yeah, what you want to hear.
Yeah, and I was looking for, I had a bad gallbladder all throughout 2018, and I thought, well, maybe that's making my PSA go up.
Yeah. Dr. Parker, is probably not too kind of typical probably to hear the story like this, right?
Oh, he loves
yes.
hearing this.
Oh, yes, absolutely.
Yeah, just somebody that you hear the word ego, not a man, all the things, right?
Oh, yes, every day.
Every day, right? And so to have somebody like Doug here sharing a story, it's pretty powerful though, right?
It is.
It is, it is. And Jenny, I know you and Doug have a pretty special relationship,
Yes.
right? Mm-hmm. Nice to have him here sharing it.
Yes.
Let's
Very
talk
much
about
so.
this stigma, Dr. Parker, surrounding prostate cancer. How do you help men, though, through that? I mean, just because those are some of those first conversations you're having when they come into your office.
Yeah, it's tough. I mean, I think first off, you have to face it head on. So, kind of beating around the bush or soft calling what we're dealing with doesn't do anybody any good. So I think being direct about it and approaching it calmly and as is with the facts. The other thing that I think is very important, and I try to talk to all the men who've been through this about, is after they've been through their treatment, they actually become the biggest advocate for other men. Mm-hmm. Part of breaking down the stigma isn't me, it's guys who've been through this talking to other men about this, reminding them that they are still a man, that they are still, you.
Yeah.
That hasn't changed. Nothing about that has changed. And so I think having men who've been through it advocate for that is the biggest part.
And it's really powerful to be talking about it. Jenny, what do you remember about first meeting Doug and trying to kind of break down through those walls and have those conversations and how those changed?
I remember he was pretty nervous, but overall, I don't think he doesn't really want to. I think he wanted to hear the information, but very, very nervous about what was going to be the future and what was going to happen, and just providing reassurance to him that he was in good hands and we'll take very good care of him.
And specifically, though, how do you personally approach those conversations?
Oh.
Because I'm sure they change over time. Because I
sure.
think you when you guys saw each other this morning in the hallway, it's like those conversations have changed over time, and you guys
very
can
much
get
so.
very personal.
Yes.
But in the beginning, they aren't quite so easy to come by.
No, and I just incorporated into my initial conversation when I introduce myself and speak with them, and I put a little sense of humor in there and say, what happens here stays here, kind of like we're in Vegas. We're going to have this conversation about personal information, but it's also our baseline and information to get to know about you. So.
But she's also warm and personable and easy to talk to about things that I didn't want to talk about. Mm-hmm. She's cute.
That helps.
She had me wrapped around her finger in like 2 minutes.
Well, I remember when we were doing our interview, you brought her name up about 6 times. I said, who is this Jenny Quinn you keep talking about? I said, is she a myth, a legend? What is she? I said, we got to get her on the show.
She was both.
She was both. Okay, so here she is. So let's talk about because you sought a second opinion here, and it led you to Dr. Parker. So you got to kind of briefly tell the story about meeting Dr. Parker. I mean, we know he's an excellent doctor, but apparently he's also an excellent dresser.
Well, I was at my low point in this little journey at the time. I was pretty depressed, and I didn't have a very good experience with the first doctor I saw. I mean, I'm sure he was fine, but Dr. Parker was my second opinion, and we're sitting there. Dana and I are in the little waiting room there, and nervous, and in he walks, sharp dressed, confident, shoulders back, and looked me straight in the eye, and I was really impressed that he actually, and nothing against doctors, but it's been my experience that they don't necessarily want to know what you know about your situation. And he said, first thing he said, you probably don't remember this, is what do you know about the situation you're in? Mm-hmm. And at the time I'd done a little research on Gleason scores, and told him that, I thought I needed to see somebody, needed to get something done, and it just went from there. And that's when he told me, look, I'm at war with prostate cancer, and I'll fight and help you. And Dana and I we walked out of there thinking, that's our guy. I said, I like him, and I like the bow tie, I like the way he dressed. We were walking to our car, and Dana said, well, half the reason you like him so much is you're both a couple of little banny roosters, the way you dress.
And you were sold.
Oh yeah.
And there you have it.
Oh, yeah.
And now he's performing surgery on you. I
Yes.
love it. Okay,
Yes.
perfect. Well, let's get to that part of the story, Dr. Parker, because I think the feelings were mutual when you met Doug, right?
Oh, yes, absolutely.
So why was surgery your recommendation for Doug? How do you, first of all, how do you kind of get to that decision, and how do you kind of go through those options with patients?
Well, I think first off, it's important to recognize surgery was one of the options. There are generally a multitude of options that we can approach. Doug was healthy, fit. One of his motivations was getting his prostate out. So when I hear that, and that's kind of a clarifying statement that people make, there are a lot of motivations that people have when they make a cancer treatment decision. When somebody says, I want my cancer out, I can almost invariably tell you the non-invasive treatments like radiation are never going to land well psychologically. So it's very easy and quick to understand that for you, that was the right option.
Okay, so it's Prostate Cancer Awareness Month.
Yes.
Last week we had somebody on that said, I don't want my prostate cancer out. I want to go through radiation. When I talked to Doug, he was like, I want it out. What's psychologically is going on when somebody said, what's the difference? I guess help me as a man, why somebody immediately goes to, I want radiation, I want to keep it, or I want it out right away.
Now, certainly this is, experience. Not everybody's gonna necessarily have what I'm about to say, but in my experience, the I want it out camp is I have something inside of me that shouldn't be there, right? I have a cancer inside of me. It being there distresses me, and so having it out is a comfort factor. I have other men for the radiation side which say, I want to remain whole. I want to be intact. And so for them, radiation fits a little bit better because that accomplishes the mission of maintaining whole.
Okay, so there's also a perception that surgery will significantly impact a man's quality of life, concern about going to the bathroom, sexual health. How do you address those concerns?
Well, first off, there is a significant impact from a quality of life standpoint. So the first thing I do is acknowledge that we are going to change things, and there is going to be, at least initially, a fairly significant negative change to quality of life with respect to urinary control and sexual function. But the more important part is understanding, what do we expect long term? What does that trajectory look like as somebody goes through life? And giving a very realistic expectation about the urinary recovery, sexual function recovery. At the end of the day, satisfaction really is driven by expectations meeting reality. And so if we set unrealistic expectations, then people aren't going to be happy with their treatment. Okay,
so initially there's going to be impact, but long term it could get better.
Right. For most men, absolutely.
Right. Okay. And so what questions did you have, and what concerns were you? You obviously were talking with Dana and your wife about this, so what was that like?
We had decided, we'd been married for 40 years at that time, that any impact, whether it's sexual or incontinence, whatever, the main thing was to save my life, put my hands in Dr. Parker's, or put my prostate, I guess, in Dr. Parker's hands.
Yeah, basically.
And so we didn't even think about that. We had 3 fine sons and just weren't worried. I think she was probably looking forward to the break.
Jessica.
Our only concern at that point was getting me to the point where I could start moving forward and getting well.
Yeah. You always trip me up. Okay, on that note, I'm going to bring in Jenny. So what do you do when patients like Doug have questions about recovery and those questions about sexual function and urinary issues? I mean, you have to have those conversations as well.
And I learned from the best in listening to his conversation about how he counseled them initially. And so it's just a very similar conversation each time of how what's going to happen afterwards. And we have tricks up our sleeve to always help them to recover and get better.
All right. So how long was it till you could get back up on the actual horse?
Well, I recovered very quickly from the prostate surgery, and to be honest, once I put my life in his hands, it was a piece of cake. It was probably right about 6 months, because I had some other health issues, completely unrelated to my prostate cancer, that kind of held me back for a little bit. But it was about 6 months I was back on the horse, and the recovery from the incontinence and all that was very quick for me. I was better after the surgery than before.
And you said this is like the best time of your life. You said this is like one of the best things that ever happened to you.
Strangely, yeah. It's just because I live more in the moment. I'm more content all the time. I'm not always happy, but I'm content. My wife Dana gets irritated with me now because I don't get irritated enough at certain things, and I just say, "Hey, I'm cool. Whatever. This is easy.
This is easy. We have some photos of you and Dana, and through the years, it's been many years that she has had to spend with you, putting up with you.
Jessica. We're coming up on 48.
48. 48 blissful years that she has spent with you. It's been a lovely, lovely journey. But she's been amazing. She's hilarious, and I love spending some time out there on your property with both of you. But
we're
she's
sure
been
glad
amazing.
you guys came out.
And how did this diagnosis change your relationship? I mean, you've been talking about how you guys kind of made all these decisions together, but yeah, you said it.
We're tighter, we're closer than we've ever been.
That's it. That's amazing. And the boys, you have your 3 boys?
I do, and they're all, I hammered on them, and the older 2 are in their early and mid 40s. My youngest is in the Army, and he's in his late 30s, expecting a son, and they all yearly now are establishing their PSA baselines, and we're all on board.
Love it. Be sure to ask your questions if you have any. You can use the chat on YouTube or Facebook. You can email the Medical News Network. That information is on your screen. Anthony, I can hear you in my ear. Let's turn to some signs and symptoms with prostate cancer. Dr. Parker, can you walk us through these? Because these are important for people who are watching and listening, because I want people to know what to be on the lookout for.
Absolutely. So I think this first slide, or the first thing, is the most important. So most men with prostate cancer have no symptoms.
That was me.
Yes.
That was you, yeah.
And that's actually what I would say is one of the most challenging things about this disease, because it's one of the few diseases where I tell somebody they have a problem, they don't actually come to me with a concern. So most prostate cancer, even up to fairly advanced prostate cancer, has absolutely no symptoms. So if you're relying on symptoms to tell you when you have a problem, you may miss the window for cure, and you may miss the window for appropriate treatment. So that's why it's so incredibly important to have that PSA test done, even if you feel fine. I think the next was about advanced prostate, or early prostate cancer warning signs. So blood in the urine and semen and problems urinating may or may not be related to prostate cancer. So I would say if you're experiencing those things, that doesn't necessarily mean you have prostate cancer, but you should be checked out. Advanced disease. So these signs here, so erectile dysfunction, pain in the hips, bones, areas like that, weakness, weight loss, feeling tired. To be very honest, those happen when men have incredibly advanced disease. So by the time prostate cancer causes symptoms like this, most of the time we're not talking about curative prostate cancer, we're talking about how do we control the disease. With that said, you see these things on this slide. Don't immediately jump to, if I have these symptoms, I have advanced prostate cancer. Erectile dysfunction, for instance, is a very incredibly common problem in men as we age, so that's not invariably associated with prostate cancer. In fact, most of the time it's not. But the point here is that by the time prostate cancer does cause symptoms, we're dealing with a very different disease than what we're talking about today.
And do we have a full screen on the screening guidelines? Very important, because those have changed.
Correct, they have. So screening guidelines have evolved in the last couple of years. We used to recommend screening starting in the mid-50s. Now we understand that screening needs to start much earlier, so 45 years in men who have no family history, no elevated risk, and really it should begin at 40 in black men, men who have a family history of prostate cancer, men who have a family history of genetic syndrome, so genetically associated cancers like breast cancer, ovarian cancer, pancreatic cancer. And then it all begins with a PSA test, as simple as that, just a blood test. The one challenge is not every primary care physician may know these guidelines, and they may not necessarily offer PSA testing. So this is where men really need to be advocates for their own health and ask.
Is there controversy around this PSA test?
Oh, yes.
Okay, tell me about that.
So controversy, it has some historical reasons that it developed. So in the early 90s with PSA testing, when it really first started kind of taking over, we diagnosed a lot of men with prostate cancer, and we treated a lot of men who did not need to be treated. And so there's this concept of over-treatment. We offer treatment to men who were never destined to have a consequence from their disease. Now we know better, and so we're much better at selecting the men who actually need to be treated for their disease. But that concern and that risk of over-treatment still exists. And so a lot of primary care, again, the people who offer this test are somewhat concerned about ordering the blood test for fear that this may start us down a pathway where somebody who doesn't need something gets offered it.
Let's talk about family history, because you certainly had it with your grandfather and your father. How important is it? How do people, what kind of conversations should people be having? And maybe Jenny, I mean, talk to us a little bit about that. What conversations should people be having with their family members? And we know Doug has 3 sons and grandsons.
Yeah. Family history is very vital. I mean, especially letting us know. Those are all of my nosy questions that I ask patients of if you have any family history of any types of cancers. And so with, and being nosy and asking them if they have children. If you do have a prostate cancer and a significant family history, your children will be impacted and they need to be checked as well.
What do you remember from when your dad was diagnosed and your grandfather was diagnosed? Do you remember even talking about it back then?
No. Just my grandfather, he didn't die from prostate cancer. He probably had one where watchful waiting would have been okay, but I can still remember that the doctor told us, well, he happens to also have prostate cancer. And then with my dad, he never got his PSA checked or anything like that. And by the time they discovered that he even had cancer, he had permanent spread all through his body. So, but they were just like me.
Denial.
Denial.
Yeah. Dr. Parker, so what would the treatment options look like? I mean, take us back, 30, 40 years compared to what we have today. I mean, compare that.
I mean, certainly we've had a lot of technical advances. Now most surgery, for instance, done robotically. Back then it would have been done open, so through a big incision where we use our hands to remove the prostate. Consequences from that were substantial. So we've gotten better there. Radiation treatments were much cruder, so how the radiation was delivered caused a lot more collateral damage. So things have thankfully evolved.
Yeah, and screenings and
yes.
talking about it.
Yes.
Yes. And just talking about it, right?
And I think that's one gigantic change that we're seeing is generationally, your parents' generation would never talk about this, right? So I would ask men, what do you know about your family history? And a lot of men wouldn't even know what you knew. And thankfully now men are much more open about sharing history and giving their kids that knowledge, and that's going to be vital for, again, appropriate screening.
Yeah, and huge for him, his boys, boys, so that's great. Jenny, what does Doug's post-care look like, follow-up care?
So we see them every 3 months for the first year, check a PSA, and very similar conversation of how they're doing as far as urinary control and sexual function. Just talking about how the recovery is going, and then having that conversation if we need to help them out with other interventions. So,
Dr. Parker, how important is it to have someone like Jenny on your team? She had said she's kind of an extension of you, but I would imagine you were like quite a bit on her as a part of your team.
Oh yes, I could not do what I do without Jenny. I mean, both just logistically, I'm in the operating room half the time, which means I'm not available, right? I can't help out if Doug or somebody else has a problem. I'm in the OR. I'm not there, right? Because the person who I'm taking care of at that moment is the most important person at that moment in time, rightfully so. So having Jenny really helps that, but also it's Jenny. So, I mean, her personality and who she is really, I mean, it helps me do a better job.
Yeah, that's what I said. I'm telling you, when I interviewed him, he just kept bringing Jenny up. So when I got back, I emailed you. I said, I think we need to have this Jenny come on because I think she's kind of a big deal around the health system. So here she is.
She's the first KU nurse that's ever been stalked on my chart.
Okay.
I bore them both, sending them pictures of, hey, I'm so happy and doing so well. Thank you.
Okay. Well,
That's definitely not a bore.
All right, we'll keep the stalking going. Love that. Love that. All right, let's get to some questions from our viewers this morning. Ruth wants to know, are there any studies that show exercise, diet, or weight reduce the risk of prostate cancer?
So interestingly, yes, there is some increasing data that would suggest that better weight control, better glycemic control in particular, does reduce the risk of prostate cancer, both development but progression of the disease. And so that's an area where there's a lot of expanding research. So for instance, there's a trial that's being done out at MD Anderson looking at the GLP-1s, so the weight loss drugs, to see if they may actually reduce the risk of progression.
Okay, Jeremy has a question and a very funny comment. You're going to love this. Question is, it seems like prostate cancer is nearly inevitable if you live long enough. We've heard that. What affects whether it's a wait and see type or an aggressive, we need to deal with this right now type?
So there's a grading system we use in prostate cancer. It's a scale from 1 to 5, where 1 is the least aggressive and 5 is the most. And essentially, 1s absolutely are not going to cause harm. As you move up that scale, then we move into the realm of this is aggressive and we have to do something.
And Doug, you said yours was fairly aggressive. What is fairly aggressive?
It was.
You know what's funny is we've now known each other long enough that I haven't looked back at your pathology to remind myself, so shame on me. I think it was a 2 or a 3, so it was kind of in that middle range where we would say it's aggressive enough that it will cause harm if we don't do something.
Jeremy says, and Doug, as for manliness, I'm pretty sure you could still whoop me in a fight. So thanks so much for sharing your story.
I don't think I can whip anybody in a fight.
I bet you could. I bet you could. This is just, this has been a fun morning, so thank you for sharing your story.
Well,
I appreciate
thank you
it.
for having me.
I really love
Thank
this.
you too, again.
Of course.
Just question, I want to just get some kind of final thoughts today, but Jenny, what's the big takeaway? What do you want people to really take away from this conversation who are listening and watching?
Just like everyone's kind of said, be an advocate for your own health, and being aware of what you're supposed to do. I see a lot of patients for new elevated PSAs, and I hear a lot of patients don't get their PSA checked regularly and or have their rectal exam performed regularly. So that is one of my biggest pitfalls for patients too. I know it's not a pleasant experience, but please have it done.
All right, thank you for that tip. All right, Doug, what's the big takeaway from your story? What do you want people to really hear from you today?
That there are folks like Dr. Parker and Jenny Q and KU that can help you and save you. Don't delay. Like Dr. Parker said, just face it head on, and that's the best way to go.
Thank you for sharing today.
Thank you.
All right, Dr. Parker, wrap us up on this Friday. What do you really want us to take away today?
Well, Jenny stole my favorite thing, which is be an advocate for yourself. So with that out of the way, I would say don't be afraid of this. I mean, I think there's some subtext here about how men are unwilling or afraid to talk about it, afraid to face it. Don't be afraid. That's going to get you in more trouble than just facing it and being open about it. So that's what I would say.
All right, the guys in the back want you to show off your hat. And there's hat etiquette, okay? So you came in with your hat. I said, oh, you're going to wear your hat on the show today. And you said?
I said, well, typically I don't wear it inside, and I certainly would never wear it talking to ladies.
Okay. Because
That
that's
sounds sexist, doesn't it? You don't like that, do you, Jessica?
Jessica. I think that looks pretty handsome. I like it.
Great.
I think I'll let you wear it for this one. I'll let you get away with it this one time.
All right. Okay.
Stetson.
I'll
all right,
break the rules
Stetson.
for you, but
all
just
right.
once.
This once. All right. And then you can't lay it down. What's the other etiquette? You can't lay it
Well,
down?
if you lay it down, you do it like that because all your luck's in here.
Okay.
And you don't want to spill it all out.
All right.
Plus, it messes up the contours.
All right. I love it. I'm coming back out to see you again. This is so fun. This has been so good. All right. Thank you so much for being with us.
Thank you.
All right. Thanks to both of you as well.
Thank you.
All right.
Thank you for
Thanks to
having
all of our guests as well. Have a great weekend. We'll see you back here on Monday. Coming up Monday on the Morning Medical Update, an elite swim coach known for training Olympic hopefuls suddenly finds herself on the other side of perseverance. Diagnosed with acute myeloid leukemia, she faces the toughest challenge yet, a fight for her life. I'm Jessica Lovell on the next Morning Medical Update. After grueling rounds of chemotherapy and a bone marrow transplant, the University of Kansas Cancer Center helped her emerge with a renewed purpose and perspective. Monday at 8.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcast. Now, everywhere podcasts are available.